Okay, good evening and welcome to today's discussion. This, as usual, is Air Clinic's live stream of PLAB-1 discussion class. All right. So we are still in cardiovascular system, and we're going to continue from where we stopped the last time. Okay. So the question here is about a 7-year-old man who presents with palpitations. Then ECG shows an irregular rhythm and heart rate of 140 beats per minute. Is otherwise stable, blood pressure is 124/80. What is the most appropriate management? Right. Among the options, we have bisoprolol, mcqs, ACE inhibitor, digoxin. First of all, what's the diagnosis? The diagnosis will guide us. Irregular rhythm. Okay, with palpitations and heart rate of 140 beats per minute. What do you think? All right. Seems you don't have any idea. Irregular rhythm. Irregular rhythm is atrial fibrillation. All right. Irregular rhythm and heart rate of 140 beats per minute. All right. It's not ventricular tachycardia. Okay. Then there's palpitations as well. So, and they just told you that the patient is stable. All right. So I told you that in management of atrial fibrillation, I want to consider whether the patient is stable or unstable. So this patient is stable. You don't need cardioversion. So you can give medications. Now, because he's an elderly man, 67-year-old, okay, you want to consider rate control beyond rhythm control. Okay, like I told you yesterday that the indications for rate control in management of atrial fibrillation include a situation where a patient is elderly. So an elderly patient, you tend to go for rate control. Okay. Then people that have chronic atrial fibrillation, like atrial fibrillation that is persistent or permanent, has lasted a long time, you go for rhythm control, for rate control, I mean. Then for patients that rhythm control has failed, you go for rate control as well. So now rate control medications I told you include calcium channel blockers and beta blockers. All right, those are the two. And digoxin is also a rate control. Then rhythm control is where you now have amiodarone, all the other antiarrhythmic agents. All right. So now, among these options, which one is not ACE inhibitor? Is not ACE inhibitor? Is not digoxin. Digoxin is also rate control, so it's between digoxin and bisoprolol. All right, but this one comes first. First line. Bisoprolol is first line of rate control. So that's the answer. All right. So the key is A, bisoprolol in acute atrial fibrillation, that's atrial fibrillation less than 48 hours, if stable rate control by verapamil, that's if stable, you should do a rate control by verapamil. If this patient was diabetic or had asthma, any of the contraindications to beta blocker use would have gone for verapamil, which is the second line. All right. Then calcium channel blockers as well can also come up as first line. Okay. So verapamil 40 to 120 milligram 8 hourly per oral, or bisoprolol 2.5 to 5 milligram per day per oral. Right. In chronic atrial fibrillation, rate control with beta blocker or rate limiting calcium channel blocker. All right. Just a summary of what I explained. Just understand that once you see an atrial fibrillation, you want to ask yourself, is this patient stable or unstable? If the patient is stable, okay, let me say, if the patient is unstable, like patient is not stable, maybe blood pressure is hitting the roof, maybe patient is dizzy and going unconscious, you want to do something quickly. And what you need to do quickly for an acute atrial fibrillation is that cardioversion, all right? You want to quickly do a cardioversion, okay? So that's one on its own. Then if patient is stable enough, all right, stable that you can wait, you don't need to do something quickly, all right? So you can now use medications. Now, depending on the age, you will now choose rate control or rhythm control. All right. So an elderly man, you go for rate control. And the rate control medications include calcium channel blockers as first line, beta blockers as first line. Okay. Second line, you have digoxin. All right. The 8-year-old lady complains of falls to the ground without any warning, maintains consciousness, no confusion. She says this has occurred at a number of times. What is the diagnosis? 8-year-old, all right, complains of falls to the ground without any warning, that's sudden falls, then maintains consciousness. She falls, she grows limp and falls, but she's still conscious and no confusion. She says this has occurred at number of times. What is the diagnosis? One is Stoke-Adams syndrome, hypoglycemia, vasovagal syncope, drop attacks, epilepsy. What do you think is the diagnosis? Falls to the ground without any warning, maintains consciousness, is not confused. So patient essentially just fall. You're welcome, Dr. Sochi. Say vasovagal syncope. Doesn't syncope imply that a patient loses consciousness? 68-year-old lady. So it's an elderly woman. You could be correct, though. We're just questioning ourselves. Does syncope imply that the patient is conscious or unconscious? Which of them? Possibly, possibly, So she could be drop attacks. All right. So we have Stoke-Adams attack. Fine. But Stoke-Adams syndrome, um, it has to do with arrhythmias, right? Cardiovascular system, which leads to transient loss of consciousness. So in the definition of Stoke-Adams syndrome, there is transient loss of consciousness, of which the patient regains consciousness again within 1 or 2 minutes. So in fact, less than 1 minute, patient has regained consciousness, but it passes out, so he loses consciousness. Hypoglycemia, of course, patient, if it's severe enough, patient will lose consciousness. All right, patient will lose consciousness. And there will be other symptoms like sweating. There's neuroglycopenic symptoms. There's neurogenic symptoms. So drop attacks. All right. Then epilepsy. Of course, epilepsy, if it's generalized tonic-clonic seizure, the patient is supposed to lose consciousness. All right. So the only thing that stands out here is drop attacks. But let's see. So we are correct. Drop attacks are sudden spontaneous falls while standing or walking with complete recovery in seconds or minutes. There is usually no recognized loss of consciousness and the event is remembered. So it seems drop attacks are like weakness, muscle weakness, all right, rather than any other pathology. So it is drop attacks. For those just joining us, Dr. Agatha and Dr. Bishop Prince, you are all welcome. All right. So we are on the second question for today. It says a 68-year-old lady complains of falls to the ground without any warning, maintains consciousness. All right. So this was the question. Falls to the ground without any warning, maintain consciousness and no confusion. So she says she has had this occur a number of times. What is the diagnosis? We ruled out Stoke-Adams syndrome because Stoke-Adams syndrome, there's normally transient loss of consciousness, all right, associated with it. And it has something to do with arrhythmias, okay? Then hypoglycemia, of course, hypoglycemia that is severe enough to cause symptoms will definitely lead to loss of consciousness. Vasovagal syncope, that word syncope implies loss of consciousness, right? So vasovagal, and usually associated with parasympathetic overdrive, okay? Then epilepsy was correct. Drop attacks are said to be a sudden spontaneous fall while standing or walking. So the patient could just be walking or just standing and suddenly he just drops. But he's conscious, he or she is conscious and knows what happened, recollects everything. There was no loss of consciousness, no confusion. Right. So it seems it's a muscular whatever weakness with complete recovery in seconds or minutes. There's usually no recognized loss of consciousness and the event is remembered. All right, let's find out more about drop attacks. So the same definition is a sudden loss of consciousness. They stem from diverse mechanisms, including orthopedic causes. For example, like we saw that the woman is a 7-year-old, is an elderly woman, right? So orthopedic causes, for example, leg weakness or knee instability is very important, right? Knee joint instability. So hemodynamic causes, for example, transient vertebrobasilar insufficiency, all right? Type of interruption of blood flow to the brain, and neurologic causes. Okay, so there could be orthopedic causes, um, vascular causes, and neurogenic causes. All right. Then, such as epileptic seizures or unstable vestibular function, among other reasons. Those afflicted typically experience abrupt leg weakness, sometimes after sudden movement of the head. The weakness may persist for hours. So the term drop attack is used to categorize otherwise unexplained falls from a wide variety of causes and is considered ambiguous medical terminology. All right. By definition, drop is a of using any falls that do happen. All right. Let's look at Adams. Which there's intermittent complete heart block. Yeah. So you see that it follows. Yesterday we talked about different types of AV nodal block, and we said that third degree heart block is the complete heart block. All right, because there's complete obstruction, complete synchrony between atrial and ventricular contraction. So you now have this complete heart block. So Stoke-Adams syndrome is a periodic fainting spell You can see the words fainting spell, so the patient loses consciousness, right? In which there is intermittent complete heart block or other high-grade arrhythmias that results in loss of spontaneous circulation and inadequate blood flow to the brain. Like, if you understand your anatomy and physiology, you know that the heart pumps blood to all over the body, right? So if for whatever reason there's a serious arrhythmia, in this case a complete heart block, all right, which means the atrial is contracting, but the ventricles are not in synchrony with it. So it means there will be no blood pumping to other parts of the body within that period of time. All right. So, and the part that is particularly vulnerable is the brain. So once the brain doesn't get something for a few seconds, the person will lose consciousness. All right. So that's what happens in Stokes-Adams syndrome. So it's periodic, but after a short while, as the patient lays on the floor, blood flow to the brain improves and patient wakes up again. All right. So that's what happens, characterized by an abrupt decrease in cardiac output and loss of consciousness due to a transient arrhythmia, for example, bradycardia due to complete heart block. Right? Early an attack occurs without warning, leading to sudden loss of consciousness. Okay, so drop attacks versus Stokes-Adams syndrome both occur without warning, just occurs, right? But this one is associated with loss of consciousness, while drop attacks, the person recollects fully the event, right? Presence, usually twitching, okay? There may be epileptiform seizures, hypoxia, etc., etc. So causes, we've mentioned, is a temporary lack of cardiac output, and it can be associated with bradycardia from complete heart block, paroxysmal supraventricular tachycardia, atrial fibrillation, all right? So Stokes-Adams syndrome is a follow-up of all these arrhythmias, okay? So Stokes-Adams attacks may be diagnosed from the history with paleness prior to the attack and flushing after, particularly characteristic. So the patient is pale before the attack, then flushes after the attack. All right, so you will see that in white people, of course. Not easy to see flushing in blacks. All right. So the ECG will show you the type of pathology the patient has. If it's a complete heart block, high-grade AV nodal block, other malignant arrhythmias, you will see it. So treatment, initial treatment can be medical, involving use of drugs like isoprenaline or epinephrine, and temporary cardiac pacing. I think this is where you now get it right. Temporary, you can do a temporary one, or you do a permanent cardiac pacing with permanent cardiac pacemaker, all right? Then prognosis, if undiagnosed or untreated, so Adams syndrome has a mortality of 50% within a year of the first episode. So this mortality is very high. So it means once you find a patient that has Stokes-Adams syndrome, you must do something immediately. Else, you may not see that patient again before the end of the year. All right? Prognosis following treatment, when you insert a permanent pacemaker, very good prognosis. Good to go. 68-year-old man gets repeated attacks of loss of consciousness and transient ischemic attacks, right? What is the most likely cause for this? 1, atrial fibrillation. 2, mitral stenosis. 3, hypertensive obstructive cardiomyopathy. 4, aortic stenosis. 5, carotid artery stenosis. 8, there's recurrent LOC, loss of consciousness, and transient ischemic attack. What do you think underscores these two symptoms, together considering the age as well? Drop your answers. Carotid artery stenosis. I don't know. Other guys, no attempts. Onoya, Dr. Bishop, Dr. Agatha. Attempts so that we'll cover more grounds today. If you can reach 70%, that will help us. All right, let's attempt with Sochi's. So you're correct. It's carotid artery stenosis. So likely what this patient is having, you can see they call it a transient ischemic attack. That implies that the patient is an ischemia, okay? And in ischemic strokes, all right, you have one of the major causes is carotid artery stenosis, okay? So age is a big risk factor for atherosclerosis, you guys know. So that could have been the reason. 68-year-old man on treatment for irregular heartbeat comes to the emergency department. He has palpitations for the last 3 hours. On examination, pulse is regular at 154 beats per minute. Carotid sinus massage settled his pulse down to 80 beats per minute. What is the most likely rhythm disturbance? 8-year-old man on treatment for irregular heartbeat comes to the emergency department. All right. He has palpitations for the last 3 hours. All right. Then pulse is regular. And Agatha, are you two using the same network? All right. Pulse is regular, 154 beats per minute. Carotid sinus massage settled his pulse down to 80 beats per minute. So what is the most likely rhythm disturbance? Yeah. Of course, it's because it's regular. Pulse is regular, and there is a maneuver that was done. In fact, seeing this alone should have given you the answer. So with carotid sinus massage, pulse came down from 154 to 80 beats. All right, so it's SVT. "68-year-old man with diabetes mellitus and hypertension was noted to have cholesterol level of 3.4 millimole per liter. He was also noted to have microalbuminuria. What is the best drug to add to his regimen?" 68-year-old with diabetes mellitus and hypertension was noted to have cholesterol level of 3.4 millimole per liter. He was also noted to have microalbuminuria. What's the best drug to add to his regimen? ACE inhibitors, biguanide, statins, amlodipine. So for those of you that don't know, when you are solving a question on the app and you find out that you cannot and look at the table of normal values. All right. We pass cholesterol. It's so total cholesterol less than 5, triglycerides less than 2, HDL more than 1. All right. LDL cholesterol less than 3. So total less than 5, normal. LDL less than 3, normal. Trig less than 2, normal. So total cholesterol. I believe this should be total cholesterol, right? Total cholesterol, normal level should be less than 5, right? So this one is within normal, but he was also noted to have microalbuminuria. Okay, so this is where the issue is. We start on ACE inhibitors. That question was testing your knowledge of the normal values for this cholesterol. So if you knew the normal value of cholesterol, you will get it. But if you don't know the normal value, you will now go and choose statins because I also put it there. That's one thing about PLAB. They will make sure that everything you're thinking about, the answer will be there. All right. So you have to start getting the values into your head. And remember, they are not using, like over here, we tend to use milligram per deciliter. But over there, they're using millimole per liter. That's why the value I put for you is in millimole per liter. Okay, so total cholesterol 5, less than 5 is normal. Then LDL cholesterol less than 3, normal. All right. Then triglycerides less than 2. So 3 plus 2, 5. Okay, less than 2 is normal in millimole per liter. And HDL cholesterol more than 1 is normal. Remember that HDL being high is good, is a good thing because it's a good cholesterol. But LDL being high is a bad thing because it's a bad cholesterol. All right. So, and it's a risk factor for atherosclerosis and others. And this patient already has hypertension and DM. All right. The next question is about a 6-week-year-old child who presents with progressive cyanosis, poor feeding, tachycardia over the first 2 weeks of life, and holosystolic murmur. What is the most appropriate condition? What's another name for holosystolic murmur? It means a pansystolic murmur. All right, holosystolic, pansystolic. That means the murmur that occurs throughout the systole. All right. So, what is the condition here? Considering is a 6-week-year-old child and there's cyanosis, so it means the cyanotic congenital heart disease. Cyanotic congenital heart disease. And we know that all cyanotic congenital heart disease begin with T, right? About 5 of them, cyanotic congenital heart disease. And they put 2 T's for you there to confuse you further. So if you know, you know. If you know the causes of pansystolic murmur, it also helps you, right? So what in that tetralogy of Fallot will be the cause of the pansystolic murmur? Which component? Tetralogy means there are 4 components. Yes, it's the VSD. Thank you. So it's the VSD, but we're not going to choose, they put VSD here, so we're not going to choose VSD. Go with TOF. Tricuspid atresia. Interesting. Correct answer is tricuspid atresia. Points in favor, tachypnea over first 2 weeks of life. All right, I think it's the age 6 weeks. I think TOF occurs a little bit later, not immediately after birth. Progressive cyanosis, poor feeding, holosystolic murmur of BSD. Tricuspid. We know that tricuspid regurgitation also causes pansystolic murmur. Yeah, that's exactly what I was saying. tricuspid valve. Where is it? Tricuspid valve on the right, connecting the right atrium to the right ventricle. All right. It's a form of congenital heart disease whereby there is complete absence of the tricuspid valve. Wow. So therefore, there's absence of right atrioventricular connection. This leads to hypoplastic, undersized, or absent right ventricle. This defect is contracted during prenatal development. Okay. When the heart does not finish developing, it causes the heart to be unable to properly oxygenate to the rest of the body rest of the blood. All right. Because of this, the body does not have enough oxygen to live. Because of the lack of an AV connection, that's an atrial septal defect, must be present to fill the left ventricle with blood. Okay. Also, since so this person almost has no right ventricle, just has a left ventricle. So there's now an ASD that will now connect the right atrium to the left atrium. So also, since there is a lack of a right ventricle, there must be a way to pump blood into the pulmonary arteries, and this is accomplished by a ventricular septal defect. Wow. So there are two defects. There's ASD, there's VSD. Interesting. Causes of tricuspid atresia are unknown. So the ASD and VSD must both be present to maintain blood flow from the right atrium. The blood must flow through the ASD to the left atrium, to the left ventricle, and through the VSD to the right ventricle to allow access to the lungs. Now, wow, so much misconnections and connections. Interesting. Presentation, progressive cyanosis. Some of these things we just know them, but we don't zoom in to see what actually happens. Presentation, progressive cyanosis, poor feeding, just like they described in the question. Progressive cyanosis, poor feeding, tachypnea over the first 2 weeks of life, holosystolic murmur, as if they even took it exactly from here. Holosystolic murmur due to the VSD, left axis deviation on electrocardiography, and left axis deviation implies that there's a left heart pathology. All right. And left ventricular hypertrophy, since it must pump blood to the pulmonary and systemic system. Wow. So there's only one ventricle, essentially, because the right ventricle is hypoplastic. There's no tricuspid valve. Interesting. Well, is it compatible with life? Did they say it? Chest X-ray, decreased pulmonary blood flow, and oligemic lung field. ECG, left axis deviation. Treatment, prostaglandin E1 to maintain pattern ductus arteriosus. Modify blaloctasic shunt to maintain pulmonary blood flow by placing a whatever. They didn't say whether it's compatible with life. Let's find out. Because that's the end of this question. But since they are talking about doing a surgery, it means there's plan for this patient's life. But it will be a very tough life. It's going to be a very tough life. Is tricuspid atresia compatible with life? Most babies with TA who have surgery live well into adulthood. Follow-up surgeries, though follow-up surgeries are often needed. So that answers our questions. They can live their normal life up to adulthood, but like we suspected, there's going to be a lot of intervention. So believe you me that a poor child is not going to survive this. He's not even going to survive the first 6 weeks because they will not even be able to afford the operation and a lot of care. So possibly you are going to a place where the child has a chance. Okay. 70-year-old man, British man, hypertensive, on thiazide diuretics, needs a second drug to control his blood pressure. Which one of the following is the best choice for him? CCBs, enalapril, that's AC inhibitor, propranolol, beta blocker, increased dose of diuretic, prazosin, alpha blocker. There's a reason why they gave you all these things, I believe. It told you the age. It told he's not African American, so he needs a second drug. He has already been started on thiazide diuretics. What will you give him? Enalapril, that's AC inhibitor. What are you basing that on? Any other attempts? AC inhibitor. You know that renal elderly patients have some renal impairment. Are you aware? So when you give them AC inhibitor, it's going to cause hyperkalemia in an elderly white man. Okay. I think it's calcium channel blocker. But let's see now. Apparently. So the key is enalapril. In patients more than 55-year-old is calcium channel blocker. If CCB is not suitable due to edema, heart failure, or thiazide is preferred. In patients less than 55, AC inhibitor or ARB. Now, if patient is on calcium channel blocker or thiazide, second drug should be added. It should be one of AC inhibitor or ARB and not one from CCB or thiazide. This answer is confusing. Please say, Bishop. The normal thing that I know, like management of hypertension based on the NICE guidelines, all right, is systemic. There are like 4 or 5 stages. So the first stage, you consider an elderly patient of whatever race, okay, and that's anybody who is above 65 years old, or let me say, who is above 55 years old, whatever race, does not matter. What you are going to use is calcium channel blocker. But if the person is less than 55 years old and African American, you are going to use calcium channel blocker as well. Okay, that's on one side. But if the person is less than 55 and white, all right, Caucasian, UK, American, anyone, Caucasian, okay, you're going to use AC inhibitor. So possibly from that explanation, AC inhibitor and calcium channel blocker are in that sense stage 1 or class 1, grade 1 of management. All right. So in grade 2 now, you're going to use AC inhibitor plus what now? Grade 2 is now whichever one you started before, you will now add a diuretic to it. So is either A plus D or C plus D. That's A plus D plus C plus D. So step 1, A or C, like I explained earlier. All right. Step 2, A plus C or A plus D. You see, A plus C, that's A plus C, that's this. Let's go over here. Here is for people that are more than 55 years old. Okay, so C, then you do C plus A or C plus D, where D is the diuretic and A is AC inhibitor. So I see no reason why you should not add AC inhibitor to that patient, to that previous patient. Because it's as if in the second grade, you can actually combine AC inhibitor and calcium channel blockers, or AC inhibitor and diuretics. So that's if you're on one side. Then the other side, you can do, since you've already started diuretic for that man, the next thing that we could have done was to start C plus D. Is so C plus D, or there's nothing like C plus A or A plus D. So I don't know. In patients more than 55 B, okay, if CCB is not suitable for whatever reason due to heart failure or edema, thiazide is preferred, right? Patients less than 55 years, AC inhibitor or ARB. Now, if patient is on CCB or thiazide, second line should be added. It should be one of AC or ARB and not CCB or thiazide. Okay, but I think I get what they are saying here, Sha. Like, you've already used thiazide as first line. I think that's what they are trying to say. You already used the thiazide as the first line. So the next one now, you should either use AC inhibitor or CCB. I still think it's CCB. Okay. 70-year-old man is admitted with diarrhea, vomiting, and dehydration. Examination, you have yellow visual halos in her eyes. ECG shows bradycardia. She has a history of chronic atrial fibrillation. Which drug causes the above-mentioned side effects? Which side effects are we talking about now? Diarrhea, vomiting, dehydration, yellow visual halos in her eyes. Will you be able to see the yellow visual halo? Shouldn't it be what the patient tells you? Why are they saying on examination? Okay, ECG shows bradycardia, and patient has chronic atrial fibrillation. So is it nifedipine, ramipril, atenolol, lithium, or digoxin that will cause such a symptom? Bishop Prince thinks it's atenolol. beta blocker. Beta blocker, does it have these symptoms of diarrhea, vomiting, dehydration, yellow visual halos, xanthopsia? Yeah, that's classical for digoxin. Is digoxin most likely? It's not atenolol. Yeah. Digoxin toxicity causes diarrhea, nausea, vomiting, dehydration. Okay, xanthopsia, which is yellow visual halos around lights. Okay, so this is actually what patient is supposed to tell you, not you telling it, not you. You cannot see it, but it's the patient that sees it. It's halos around light. Then bradycardia. Of course, we know that um, beta blockers, digoxin, all these rate control medications tend to lower the rate of the heart by increasing AV nodal delay. All right. So history of atrial fibrillation is also a clue of digoxin use. So the two major clues of the fact that it's digoxin is that xanthopsia, which is yellow visual halos, and history of atrial fibrillation. Right. 70-year-old man with long-standing anxiety is seen in the outpatient department. She complains of her heart skipping a beat quite often. This particularly occurs when she's trying to get to sleep. Palpitations are never sustained. What is the most likely rhythm disturbance? 70-year-old with long-standing anxiety seen in the outpatient department. She complains of her heart skipping a beat quite often. That's palpitations. Particularly occurs when she's trying to get to sleep. Palpitations are never sustained. What is the most likely rhythm disturbance? Supraventricular tachycardia, ventricular fibrillation, ventricular tachycardia, ventricular ectopics, atrial fibrillation. So it seems you all are in agreement. Okay. So not sustained. Yeah. Yeah, that's the key word. Palpitations are never sustained. Ventricular ectopics, from the given option, the most likely is V-ectopics. If it occurs in a normal heart, though symptomatic, it is benign in nature. Or if it's secondary to heart disease like myocardial infarction, it may precipitate to more life-threatening arrhythmias like VFib. All right. This is the clincher, never sustained. Only occurs when she's trying to, particularly occurs when she's trying to get sleep. Never sustained. Ectopics. All right. So a 72-year-old man has been advised to have antibiotic prophylaxis for some years now before dental treatment. He has never experienced chest pain. 3 weeks ago, he noticed breathlessness on exertion for 1 week. All right. He had autopnea. His pulse is normal. What is the most probable diagnosis? 72-year-old man is supposed to be on antibiotic prophylaxis for some years now before dental treatment. He has never experienced chest pain. 3 weeks ago, he noticed breathlessness on exertion. And for 1 week, he had autopnea. All right, that's like symptoms of heart failure. Pulse is normal. What is the most probable diagnosis? Thick regurg, ischemic mitral regurg, pulmonary stenosis. This one is a strong question. But I think there's something here. Has been advised to have antibiotic prophylaxis for some years before dental treatment. This is a implying that he has had rheumatic heart disease, commonly affected by rheumatic heart disease. Infective endocarditis or rheumatic heart disease. Anyway, where you are going, it should be more of IE. Mitral valve prolapse. Let me see. Anyway, mitral stenosis. The key is mitral stenosis. Mitral stenosis is the most common valvular complication of rheumatic fever. So it's rheumatic fever, not infective endocarditis. I was suggesting rheumatic fever here. Antibiotic prophylaxis for some years before dental treatment. Like when a patient has had rheumatic fever before in the past, you don't want them to have, how does it occur again? You don't want them to have, when they are going for any dental extraction or any operations at all, you want them to be on antibiotic prophylaxis because they are at risk of IE. So I think they are all related anyway. So mitral stenosis is the commonest complication of, molecular mimicry, It's the commonest complication of rheumatic fever or rheumatic heart disease. The same question. ECG. 70-year-old man is found to be not breathing in the TCU with the following reading. What's the most likely diagnosis? We've answered this one before. C reading or SVT, ventricular tachycardia, VFib, atrial fibrillation, atrial flutter. Which one? Guys, no idea. But we discussed the same question yesterday. It's not, you don't have to put question mark. It's VFib now. Look at it. What do we call it? Sawtooth without any evidence of P waves or QRS. Sawtooth throughout. This is not compatible with life. Leave this patient for 2 to 3 minutes without defibrillating. you're going to lose the patient. So you need an urgent cardioversion. 360 joules energy. This is where you do shock, charge, and smash. Okay. This is ventricular fibrillation. We're getting close to the end, 69%. 72-year-old man presents to the ED with chest pain. The following ECG was taken. What is the most likely disease? What is going on here? Posterior MI, anterior MI, inferior MI, lateral MI, non-ST-MI. There's something going on in the leg 3. Leg 2. It's not very clear anyway. It's not very clear. I'll give you that one. It's not very clear. It's not very clear. Non-STMI. It's not very clear. Seventy-two-year-old presents with polyuria and polydipsia. The fasting blood glucose is 8 and 10 millimole per liter. Okay. BP is 130/80, and the level of cholesterol is 5.7. Total cholesterol 5.7 is elevated. There is microalbuminuria. What is single most appropriate next management? What are the problems with this patient? Polyuria, polydipsia, which are features of diabetes. All right. Fasting blood glucose is, why did they say 8 and 10? Is normal. Level of, okay, so there's renal, there